You know that awful feeling, right?
Yeah.
That moment your dog or maybe your cat is suddenly, like, really struggling for breath.
Yeah, it's terrifying. No pet owner wants to see that.
Exactly. And it's something vets see, well, pretty often. Today we're diving into one specific reason this can happen, something called pneumothorax.
Air in the chest cavity, essentially.
Right, we've got this stack of sources you sent over, all about pneumothorax in dogs and cats.
Yeah.
And we're going to, do our deep dive, pull out the really important stuff, the key insights. The goal here is to help you get the basics of this condition.
Sounds good. Where should we start?
Okay, let's unpack it. Like, at the most basic level, what is pneumothorax?
So fundamentally, it's air building up in the pleural space.
That little space between the lungs and the chest wall.
Exactly. Normally just a tiny bit of fluid there. And your sources really highlight that it gets categorized by cause so traumatic, from an injury.
Like getting hit by a car or something.
Yeah, or it can be spontaneous. That just pops up seemingly out of nowhere, no obvious trauma. And they also break it down by, how the air is behaving. You've got closed pneumothorax, no hole in the chest wall.
Air's leaking from the inside then.
Right. Then there's open pneumothorax, where there is a connection, a defect, between that pleural space and the outside world.
So air just rushes in.
Pretty much. And then the really critical one, tension pneumothorax.
Uh-oh. That sounds bad.
It is. It's a type of closed pneumothorax, but it acts like a one-way valve. Air gets in when the animal breathes in, but it can't get out when they breathe out.
Oh, wow. So the pressure just builds and builds.
Builds and builds, yeah. Pleural pressure gets way higher than atmospheric. Really dangerous.
Right, okay. So normally that pleural space, it's like this potential vacuum, right? The fluid kind of glues the lungs to the chest wall.
Yeah, exactly. It tethers them, so as the chest expands, the lungs expand.
But if air gets in, poof, the lung just sort of collapses away from the wall.
Precisely. And where that air comes from, like you hinted, depends on the type.
So for closed, you said it's leaking from inside.
Yeah.
Like the lung tissue itself.
Lung tissue, yeah, or maybe a large airway. Sometimes even the esophagus can be the source.
Okay. Intention, that one-way valve thing.
Usually that's a flap-like tear. Could be in the lung or maybe the lining, the pleura. Lets air in, snaps shut on the way out.
And open is,
Yeah.
well, simpler. Just a hole in the chest wall.
Yeah, direct communication with the outside. Air comes straight in from the atmosphere. Pleural pressure equals atmospheric.
Got it. And spontaneous. You said that's from underlying lung disease.
Exactly. Something already wrong with the lung ruptures, basically, and lets air leak out.
Okay. Now, something that jumped out from the sources, this idea that it's often bilateral, affecting both sides.
Yeah, that's a really crucial point.
Both sides. How does that happen? Does the air just seep across?
Kind of, yeah. There are these things called mediastinal fenestrations. Think of them like tiny little holes or weak spots in the membrane, the mediastinum, that divides the chest down the middle.
Ah, so the air can cross over from one side to the other through these little openings.
Exactly, which is why it's so significant clinically. You might only see air on one side on an x-ray initially, but you've got to be ready for it to affect the other side too. A leak on one side can become a two-sided problem pretty fast.
Wow, okay. That makes sense why it's serious. And it's not just the lungs collapsing, is it? The sources mentioned it hits the cardiovascular system too.
Absolutely. Respiratory is obvious, but cardiovascular too. That high pressure inside the chest, especially with tension pneumothorax.
It squeezes things.
Yeah, it literally compresses the big veins trying to return blood to the heart. So less blood gets back, less blood gets pumped out. It affects circulation.
So they can't breathe properly and their circulation is compromised. Double whammy.
It's a profound effect on critical body functions, yeah.
So, okay, how common is this? The stats in the sources were pretty eye-opening. Traumatic pneumothorax, over 40% of chest trauma cases.
That's right. And specifically, 11 to 18% of dogs and cats after being hit by a car.
And this one blew my mind, about 25% of cases with intrathoracic grass-ons. Hold on. Grass-ons in the chest. How does that even happen?
Right. It sounds bizarre, but the sources suggest they get inhaled or maybe migrate from somewhere else, and they can actually work their way through and puncture lung tissue or airways. Creates a leak.
That's incredible. And dog bites, 70%.
70% of dogs with thoracic bite wounds had pneumothorax in one study mentioned.
Yes, this is huge. Really shows how damaging those bite wounds can be.
Definitely.
So who gets this? Dogs and cats, clearly. Anything else? Like breeds.
Well, the spontaneous kind seems to pop up more in large dogs, deep-chested breeds. Siberian Huskies get a specific mention as maybe being overrepresented in some data sets.
Interesting. Okay, causes, the sources break this down really well. Traumatic is, well, trauma.
Right. Blunt trauma, like we said.
Yeah.
Penetrating injuries, chest, even the neck sometimes. And then there's iatrogenic causes.
Stuff that happens because of medical procedures.
Exactly. After things like thoracocentesis, tapping the chest to get fluid or air out. Thoracotomy, which is chest surgery. Lung aspirates.
Even simple things.
Potentially, yeah. Like if the cuff on an endotracheal tube, the breathing tube for anesthesia is inflated too much, or if ventilation pressure is too high during assisted breathing. Esophageal perforation is another one listed.
So accidents, but also sometimes medical procedures, though rarely, can trigger it.
Wow. And the list for spontaneous causes looked really long. Lots of underlying lung problems.
It's definitely not just one thing. The sources list bullous emphysema, that's like fragile, stretched out air sacs in the lungs. Probably the most common cause in dogs.
Okay.
Pulmonary bulli or blebs, just different kinds of weak spots or air bubbles. Those migrating foreign bodies like the grass-ons we talked about.
Right.
Lung tumors, abscesses.
Feline asthma was on there, bronchopneumonia, fungal infections. Even parasitic diseases, heartworm causing bubbles that rupture. Yeah, paragonomus, which is a lung fluke, and Dirofilaria amitis, heartworm, causing changes that lead to rupture. Congenital stuff, too, like cysts or abnormal lung development from birth. And air can even track from the mediastinum, that space between the lungs.
Okay, so summing up risk factors, trauma, obviously, chest or neck procedures, issues with ventilation or intubation, underlying lung disease is a big one, and those sneaky migrating things like grass-ons.
That covers the main ones, yeah.
Okay, that gives us a really good sense of what it is and why it happens. So let's shift to figuring it out. If you suspect pneumothorax, what do the sources say? What signs do you look for? How's it diagnosed?
Well, history is key. You definitely ask about any recent trauma for that type.
Makes sense.
For spontaneous, it might be really sudden, or maybe it's been coming on slowly. Sometimes there's a history of breathing issues already. And you always ask about recent procedures, chest taps, surgery, anesthesia, intubation.
Right, checking for those iatrogenic causes. And on the physical exam, what are the clues?
You're looking for respiratory distress. That usually means breathing fast, tachypnea. Increased effort, maybe using their abdominal muscles a lot to breathe.
Like belly breathing.
Yeah, exactly. Sometimes they have orthopnea, meaning they can only breathe comfortably in a specific position, often standing or sitting up.
Okay.
A classic sign is decreased or even absent lung sounds, especially up high on the chest, dorsally, where the collapsed pulls away. But honestly, that can be really hard to hear clearly if the animal is panting heavily or really distressed.
I can imagine. Other signs.
Bluish gums or skin cyanosis from low oxygen, a fast heart rate, tachycardia.
And if it's traumatic, you might see signs of the trauma itself, right? Bruises, wounds.
Absolutely. Or signs of shock, especially if there's internal bleeding, too. Things like pale gums, slow capillary refill time, when you press the gum and see how fast the pink color comes back, weak pulses, cold legs.
What about air under the skin? Subcutaneous emphysema.
Yeah, that can be a clue, too.
Right.
Especially if there's maybe been trauma to the trachea, the windpipe, or if air's tracked up from the mediastinum.
Okay. So you see these signs, you suspect it, but what else could it be? What are the differentials?
Good question. The sources list things like pleural effusion, that's fluid in the chest instead of air, a diaphragmatic hernia where abdominal organs slip into the chest cavity, or just primary lung disease like bad bruising, pulmonary contusions, or pneumonia.
Right. So how do you narrow it down? Lab tests.
Standard blood work, like a CBC and chemistry panel, might show signs of infection or inflammation if that's part of the underlying cause, like an elevated white blood cell count.
Okay.
Arterial blood gases are really useful. They directly measure oxygen and carbon dioxide levels in the blood. You'd definitely expect low oxygen hypoxemia. CO2 can be low or high, depending on things.
And specific tests if you suspect something unusual, like that parasite.
Yeah, exactly. Like a fecal test, sedimentation if you're worried about paragonomous lung flukes.
But imaging is probably the big one for diagnosis.
Oh, absolutely critical. But, and this is important, the sources stress you often have to stabilize the patient first. Getting x-rays can be stressful for an animal struggling to breathe.
Good point. So thoracic radiographs, chest x-rays, what do they show?
You're looking for air in that pleural space. It shows up as black. And because of the air, the lung edges, the vascular pattern you normally see extending out to the chest wall, they don't reach. They look pulled back.
And the heart.
The heart silhouette might look like it's lifted up off the sternum, especially on a side view, because the collapsed ling lobes aren't supporting it normally.
Okay.
And a really key point from the sources: the collapsed lung itself can actually hide the underlying problem, especially in spontaneous cases. You might not see the bulla or tumor causing the leak initially.
So you might need to take x-rays again after you remove some air.
Often, yes. Once the lung reinflates a bit, you might get a better look. For traumatic cases, you're also looking hard for other injuries: rib fractures, lung bruises, hernias, bleeding. For spontaneous, you're hunting for that underlying cause.
And there was that interesting technical point about which x-ray views are best.
Yeah, that was neat. They found a right lateral horizontal beam view, basically the animal lying on its right side. Beam shot across horizontally had the highest detection rate. Standard views, like standing or lying flat on their back or belly, were less sensitive.
Good tip. What about ultrasound?
Ultrasound, yeah, thoracic ultrasound, or TFAST, is mentioned as a useful tool, especially good for trauma, quick bedside assessment.
What does it show?
The key finding is loss of the glide sign. Normally, you see the lung surface sliding against the chest wall lining as the animal breathes, like shimmering. When there's air trapped between those layers, they don't touch, they don't slide, you lose that glide. The sources quoted pretty good numbers for it in dogs with trauma: 78% sensitivity, 93% specificity compared to x-rays.
So it's a good screening tool. And CT scans.
CT is used more for planning surgery in spontaneous cases, trying to pinpoint exactly where the leak, the bulla or bleb, is located. But even CT isn't perfect. The sources warn it can still miss smaller lesions sometimes.
Okay. And actual procedures, besides imaging.
Thoracocentesis: sticking a needle or catheter in to remove air. That's both diagnostic, proves there's air, and therapeutic, give immediate relief.
Right. What do they use for that?
Sources mention a small IV catheter hooked up to an extension set and a 3-way stopcock lets you pull air out safely. Or even just a butterfly needle attached to a syringe. Goal is to remove as much air as you can.
And maybe bronchoscopy, looking down the airways.
Yeah, if you suspect the leak is from the trachea or a major bronchus, maybe from trauma or intubation injury, a scope could help find it.
Okay. And if you do end up in surgery or, sadly, post-mortem, what might you actually see?
Grossly, with the naked eye, you might see those blebs or like little blisters on the lung surface, or actual tears or signs of the underlying disease like tumors or pneumonia.
And under the microscope?
Histology helps tell the difference between blebs, which are kind of within the pleural lining, often at the lung tip, and bullae, which are lined by pleura and messed up lung tissue. This really brings up a key question, doesn't it? For the long haul, is just getting the air out enough, or do you absolutely have to find and fix the source of that leak?
Yeah, that seems like the million-dollar question.
Yeah.
Which leads us right into treatment, I guess.
Exactly. Treatment and management. First off, the sources are clear. These animals need inpatient care, hospitalization, until that air leak stops or at least stabilizes.
Makes sense. You need to watch them closely.
And if they're in respiratory distress, immediate action. Thoracocentesis, get that air out fast, and always provide oxygen therapy alongside that.
Okay. What about those open chest wounds, the ones letting air straight in?
That's an emergency. You need to cover that wound quickly, cleanly, with something airtight. The sources even suggest using sterile lube or ointment around the edges of the bandage to help seal it.
Just slap a bandage on.
It's a temporary fix just to stop air rushing in. But, and this is critical, it has to be followed up by placing a chest tube and then proper surgical closure of the wound once the animal is more stable.
Right, so chest tubes. When do you put one of those in?
If you can't stabilize them with just needle taps, or if the air keeps coming back really fast, needing repeated taps, then a chest tube thoracostomy is the way to go.
Okay. And how's that done? Is it complex?
It requires anesthesia, either local or general. You prep the area surgically. Make a skin incision maybe a bit further back, like rib space 11 to 13. Then you tunnel the tube under the skin forward, aiming towards the front and bottom of the chest before popping it through the chest wall around rib space 7 to 9.
Why the tunnel?
That subcutaneous tunnel helps create a better seal and reduces the risk of infection tracking along the tube. Then you secure it really well, purse string suture around the hole, finger trap suture holding the tube itself, and always get x-rays afterwards to check it's in the right spot.
Got it. Once the tube's in, how do you manage the air removal?
2 main ways described. Continuous suction is for when air is accumulating really quickly. Usually involves a special setup, like a 3-bottle system, that provides constant gentle suction and an underwater seal to prevent air going back in.
Okay.
Or if it's less severe or starting to resolve, you can do intermittent aspiration, just hooking up a syringe periodically and pulling out whatever air has built up.
And what about that scary tension pneumothorax? Is there an emergency procedure for that?
In a real life or death situation, sometimes an emergency thoracotomy, literally opening the chest cavity quickly, is mentioned. It converts the deadly tension pneumothorax into a less immediately fatal open pneumothorax, buying time to stabilize and ventilate the patient. It's drastic, though.
Wow. Okay, so when is surgery the main plan?
For open traumatic wounds, yes, surgery is needed to close them once stable. Closed traumatic pneumothorax, usually managed medically, rarely needs surgery. But for spontaneous pneumothorax, especially in dogs, the sources lean towards early surgery.
Real early.
To find and fix the underlying cause, like remove the bulla, gives the best chance of stopping it recurring. If you don't know where the leak is before surgery, they might do an exploratory thoracotomy, often opening the chest down the middle, median sternotomy, to get a good look at both sides. They also mention pleural access ports as an option for managing leaks medically long-term sometimes.
And nursing care sounds absolutely vital.
Oh, totally. 5E fluids are crucial. Most trauma cases need them. Pain control is important, but you have to be careful. Some strong painkillers, like opioids, can slow down breathing, which you don't want.
Right.
And chest tube care is meticulous. All connections airtight. They even suggest zip ties for extra security. Securing the tube well at 2 points, keeping the entry site clean, daily dressing changes, and stopping the pet from chewing the tube out.
Yeah, but that's a challenge. What about afterwards, once the air's gone, tube's out?
Strict rest. The sources say at least a week of confinement, minimal activity, helps reduce the chance of it happening again.
Okay, let's talk surgical details. There was a big warning about ventilation.
Yes, absolutely critical insight. Do not use positive pressure ventilation, like bagging an animal or using a ventilator if they have a closed pneumothorax, unless you already have a chest tube in place or you're literally just opening the chest for surgery.
Why is that so dangerous?
Because you're forcing air into the lungs, and if there's a leak, you're just pumping that air directly into the closed pleural space with no way out. You can instantly create a massive fatal tension pneumothorax.
Ah, okay. That makes total sense. Very important point. So if they do go to surgery, how do surgeons actually find the leak, especially if it's small?
Good question. Techniques mentioned include thoracoscopy using a camera if they think they know roughly where it is. In open surgery, if it's not obvious, they might fill the chest cavity with sterile saline, like a pool, and gently inflate the lungs. Then they watch closely for bubbles rising from the leak site.
Like finding a puncture in a tire.
Exactly like that. And the sources mention it's not uncommon to find more than one lesion.
So it might not be just one spot leaking.
Correct. Repair usually means removing the affected bit of lung, a partial or full lobectomy if it's localized, or maybe just suturing a traumatic tear. But it's worth remembering, sometimes even in surgery, the exact leak source can be elusive.
And you said they always put a chest tube in during surgery?
Yes, standard practice. Placed at the time of surgery in all patients to handle any air leakage or fluid drainage afterwards.
Okay. What about pleurodesis? Making the lung stick to the wall.
Yeah, that technique exists. You either sort of roughen up the pleural surfaces mechanically or instill something inflammatory like sterile talc powder to create scarring that fuses the layers together.
Does it work well?
According to the sources. Success rate is believed to be poor in veterinary patients, especially for spontaneous pneumothorax. So it's an option, but maybe not highly effective.
Interesting. And there was one other technique mentioned for persistent leaks. An autologous blood patch.
Right. That's for leaks that just won't seal, even after conservative management or surgery. You take some of the patient's own blood and inject it into the chest tube. The idea is the blood clots around the leak and plugs it. Described as pretty simple and relatively safe.
Okay. So, lots of options. How do you explain all this to clients?
Education is key. For traumatic cases, owners need to understand about hospitalization, the possibility of chest tubes, maybe surgery. For spontaneous, especially in dogs, you explain why early surgery is often recommended, but you also have to manage expectations.
How so?
You explain there might be underlying diffuse disease, that even with surgery, finding the leak isn't guaranteed and recurrence is still possible. It's about being realistic about the challenges, particularly with spontaneous cases.
Right. And follow-up. Monitoring after treatment.
Super important. Watching the respiratory rate at home, if it starts climbing, that's a worry for recurrence. In hospitals, serial X-rays track the amount of air. Pulse oximetry gives a quick check on oxygen, but arterial blood gases are really the best way to assess oxygenation, especially if there's underlying lung disease. Central venous gases can check ventilation status.
And if they still have a chest tube in.
You monitor the air production rate closely, counting bubbles per minute if they're on continuous suction, or carefully measuring the volume of air you pull out with a syringe if it's intermittent aspiration. Tracking that trend tells you if the leak is sealing.
Okay. Prevention, anything simple?
For trauma, yes. The sources basically say, keep pets confined, less likely to be injured. Can't argue with that.
True. Okay, wrapping up. Complications and prognosis. What are the risks?
Sadly, death is a risk from lack of oxygen or cardiovascular collapse. Complications can happen from the procedures themselves. Thoracocentesis, or chest tube placement, can potentially cause lung laceration, heart puncture, diaphragm, or liver injury if not done carefully.
Yeah.
And infection, pleuritis, or pneumothorax is always a risk with tubes and drains.
And the overall outlook. The prognosis.
It really depends on the type. For traumatic pneumothorax, if the initial trauma isn't too severe, prognosis is generally good with drainage. But if there's severe trauma, especially bad lung contusions, the prognosis is poor, even with intensive care.
And spontaneous.
That depends entirely on the underlying cause. If it's a nice single focal lesion, like one bulla you can find and remove surgically, prognosis can be good. But if you can't find the lesion, or if it's caused by widespread disease like cancer or severe emphysema, then the prognosis is often poor to grave.
So connecting it all back.
Yeah, if we connect this to the bigger picture, the long-term prognosis often really hinges on whether you can successfully identify and fix the reason why the air is getting into the chest in the first place, not just dealing with the air itself.
Wow, okay. We have definitely covered a ton of ground on pneumothorax. It's clearly way more complex than just air in the chest. We've gone from the basic definition, the different types, all those causes, some really surprising ones like grass-ons, to how vets diagnose it with exams, labs, imaging, and then the whole range of treatments, medical and surgical, plus the outlook.
Yeah, and diving into these sources really underscores how serious it can be and why that thorough workup is so important, especially for those spontaneous cases trying to find that root cause.
And hopefully for you listening, understanding all these details maybe gives you a better appreciation for what your vet team is dealing with if this ever happens, or maybe helps you spot those early signs of breathing trouble just a bit sooner.
Which brings us to a final thought to leave you with. Considering that risk of recurrence, especially in spontaneous cases where maybe the source isn't found or fixed completely, how does the focus need to shift? From just treating the episode that's happening right now to really managing that underlying risk long term or anticipating future problems? Something to think about.